Welcome to the another event from the foundation. If you haven't joined before, and I know there's a lot of first-time registrants, especially folks from the Stills disease group. So, welcome to everyone, especially to the new people who are joining us for the first time. And we are doing this event in honor of Rare Disease Day, which was last week, not this week, but SJIA and stills being rare diseases. We found a lot of community in that larger group, and we celebrate it yearly. We always have an event on that day, and the format we are choosing today is that we have talks by two experts, and then we'll have panel discussion and a breakout groups. So before I go further, let me just talk a little bit about housekeeping and the things to note about how we are running the meeting. So we should recommend that you turn off the full screen mode so that you can see the chat on the right side, because chat is a part of the way we run the meeting. And please do put your full name there. It's nice to know who's joining us. And you can put patient parent just to say who you are. Um, During right after the talks, we will have a opportunity to ask questions for after each talk, and then there will be a panel session where both the speakers will join in. So then you will have a chance to ask questions. We really like to have give opportunity to have lots of discussion, but we suggest that you ask questions in the chat, and one of the foundation representatives will ask that on your behalf. um, Try to keep it short, and we'll try to choose more distinct questions so that we cover as many topics as possible. So we definitely recommend during those sessions to keep a lookout at the chat. If you there is a We've set up an option for translation. I think Luciana has nicely put a screenshot here. I think if you go to the break, the more, or maybe it'll just be showing you show captions, then you can choose the language you want to see the translation in. So please go ahead and do that if you need. And if you do have Zoom issues, please chat with Luciana or Hani. They are both co-hosts of the meeting, and they will be able to help you. With that, maybe I'll just briefly introduce Luciana, who is here, who has helped set up a lot of the meeting. And if you can say hi, Luciana, so that they know who you are, and Hani. Um, okay, so with that, let's move on to the a little bit about the foundation. We always do that. The foundation was formed almost 8 years ago, and we work on building awareness and supporting research. And with our work with patients, we are in all the patient groups. We try to help patients with questions, what we do know, and we organize these periodic education events like this one. And we especially focus on helping patients who are refractory, and to help them learn about other education options to obtain second opinions, things like that. In our work with researchers, we are there to provide patient perspective for researchers across the world. We are in active contact with many researchers across the world, and we help recruit patients for studies. We organize events, which I'll come to in a minute, for researchers as well. Some of our wins, I think that we have been working for a while to try to, and this was before even the foundation was formed, we were informal at that time, to recognize the unmet needs in SJIA, the awareness of the lung disease complication, especially. More recently, awareness that for patients who are not responding to anything else, bone marrow transplantation as an option, and a few other things like that. This has been the active work of a group of parents, many of whom you will see here, some of whom I will see here. There's many more actually. And honestly, we've been focused on more on the pediatric patients, because that's where a lot of us are coming from. I have a child with SJIA. He's 13 now. He was diagnosed at the age of 1. And within 2 years has started the foundation and been working on those with for SJIA. And many of the parents have the similar stories. And we hope to engage more with Still's disease patients. So if you are a Still's disease patient, if you would like to provide volunteer for the foundation, give us some help, please reach out to us after the event. Some of our highlights from say 2024, we organized this conference, which this was the fifth next gen conference in Washington DC, and it's kind of a unique conference where we bring together patients, researchers, clinicians, regulators, and pharma to talk about what medication options are currently available to patients and what is coming down to the pipeline, what are the unmet needs, and it's a really invigorating discussion for 2 days. In the last year, we collaborate with many researchers across the world, and in the last year there were 10 scientific papers in which we had helped in some way or the other, and we were kindly included as authors. We kind of help start this project of the study of refractory patients called the Accelerate projects, and that has slowly been recruiting patients. And our focus right now, we are mostly US, honestly, and we are trying to expand to Europe. And we went to Luciana actually attended the press conference, and we hope to be back there again this year. So that's our ongoing effort. So these are some of the things we did last year. I'll go over quickly some of the patient resources that you can find on our site. If you go to our YouTube channel, you will find 138 videos on SJIA, stills, MAS. You'll find patient stories, you'll find experts, you'll find FDA, pharma. You'll find many different perspectives. It's really it's from the past, like, almost 8, 9 years. So many of them are patient directed. On our site, we have the clinical trials that we keep updated. It's a clinical trial finder. And more recently, we added something which was how to work with for educational accommodations in SJIA. And we have a toolkit for that. And we had recently organized an event about that. So that's kind of some of the patient resources. Now, how you can get involved with us? One of the fun things is that we made these socks, we call the macrophage or the SJIA socks, which have all these cells that are involved in the disease. So, and here are two of, the patients, SJIA patients wearing those socks. They're really fun socks. We have them available right now if you want to go and order a few. You can start a fundraiser. There's a lot of parents who do that. You can go donate. Then there's people who do birthday fundraisers. There's people who do T-shirt campaigns. One volunteer is planning a golf tournament. So there's all sorts of ways in which you can contribute to this. We are mostly volunteer run, and we make sure that every dollar that is donated all goes to research. Um, there is also, we have a global patient network where you can join. And right now, it's just we ask for some information about the patient, and we kind of collect that. And we have almost, how many people in our network, Luciana? Like 400, 500?
500, 500 and something. Yeah.
500 something. I hope each and every one of you, will send you a link after this event. I really hope it'll take 5 minutes, but it helps us understand the disease. It helps us reach out to patients when researchers contact us. I really hope you will join. It'll literally take 5 minutes. And we have a new website for members coming soon. We hope to have that going. Um, we are on social media, if you care to find us, more active on some than the other, but recently with the help of Hani, Antonia, Luciana, we are really trying to be more active on different social media platforms. So take your pick. Wherever you are, you can find us. um, with that, I'm going to go on to today's event and introduce our first speaker. But before that, let me just quickly talk about the structure of the event. We'll start with a talk by Dr. Canna, And we've asked him to do a 15-minute talk, up to a 15-minute talk, and 5 minutes for questions individually. And then we'll move on to Dr. Fautrel. And once again, we've asked him for 15 minutes. And then after that, we are going to have a panel discussion with both the speakers there and your chance to ask further questions. And we do find that patients really value this time to be able to ask questions directly. And then we have a guest visitor who will be joining us for a few minutes, Dr. Michael Jordan, and he'll tell us about an MAS registry that he will tell you about. And finally, we will have breakout groups, and there's different topics for the breakout groups, from topics about newly diagnosed or refractory disease or bone marrow transplantation or Still's disease group. So there's several different groups we will have, and you can join whichever one you want. Um, so with that, I'm going to move on to Dr. Canna. And Dr. Canna, I'll just at the end I'll stop sharing my slides and you can share yours. So Dr. Canna, who we have been working with for a long time, from almost the beginning of the foundation's work, is Associate Professor of Pediatrics at CHOP, or Children's Hospital of Philadelphia, one of the centers in the US which has a lot of expertise on SJIA and other related diseases like other autoinflammatory diseases. He is especially an expert on IL-18 disease, and I would be remiss if I didn't tell you that these small yellow things in these socks are the IL-18. So, and we conferred with him when we designed those. So, with that, I'm going to move on to Dr. Canna. Thank you so much for joining us.
Thank you, Rashmi. Can everybody hear me okay?
Yeah.
All right. I'm just going to share my screen, I hope. Screen one. All right. All right. All right. Are we close? Can you? I think I need to switch displays. All right. Does that look all right? Does that look okay? Can folks hear me?
Mm-hmm.
All right. Excellent. Sorry. Thank you, Rashmi. It's really, my first slide is on purpose. It's really a privilege to be part of this community for so long. I think Rashmi is really sort of extraordinary at bringing people together, not just to have them together, but in pursuit of a goal. And I think, there's been a lot of progress, certainly not as fast as we would like, but I think that's always the case. But really a dramatic improvement in the trajectory of our field, and I think a lot of that has to do with this foundation. So it's a privilege to work with you all. A few disclosures, certainly nothing that's been lucrative. So I thought I'd start with just, some questions I have to ask myself, which is, what the heck is systemic GIA? Is it a 2-year-old who's had a prolonged fever and kind of miserable, and the fever becomes kind of an every afternoon thing? There's not really any infectious symptoms. Maybe a little bit of this rash that breaks out with fever, but later on in the course, gets called Kawasaki disease and gets treated for that, but doesn't really have much of a response. All the infectious and other tests have been negative. The labs show lots of inflammation. Some rheumatologist strolls in and says, oh, the knee is swollen, and nobody really knew about that. And is that Still's disease? Is that systemic GIA? Or is it a 10-year-old who initially has some fever and then some joint pain and stiffness that kind of gets more and more painful over time? The fever sort of abates, never really had any rash, and now is just left with really kind of crippling arthritis in lots of joints, especially in the hips. And here's an MRI that really has sort of all the bad things happening. There's inflammatory arthritis, there's degenerative or osteoarthritis, there's even a little avascular necrosis of these hips. And this poor 10-year-old is going to need to have these hips replaced, and they're just biding their time until they're done growing so that they can get a bilateral hip replacement. So is that systemic GIA? That seems like a very different scenario than we just talked about. Or what about, this little 18-month-old. These are all real patients I've helped care for, who has trisomy 21 and was well until 18 months. Started developing this prolonged fever, had a big liver and spleen, had some low cell counts with anemia and platelets and liver irritation, and then low blood pressures, and things are really starting to get serious. Big workup looking for infections and cancers, and really nothing happening, and unfortunately gets moved to the intensive care unit because the blood pressures are so low. And so my answer is yes, all of these are sort of underneath this umbrella of systemic GIA Still's disease, which really creates a challenge, I think, for trying to put our finger on what we're actually talking about. And then when did this syndrome sort of become systemic GIA? The same patient who outside of this acute presentation is always just, kind of teetering on the edge of a flare. And then someone just on a routine check notices that the fingers look kind of puffy, and sometimes erythematous, which leads them to get a chest CT, which has this really funny pattern that looks a little bit like an aspiration pneumonia sometimes. And then, maybe they move forward with a biopsy and it has a pretty unexpected finding of pulmonary alveolar proteinosis. Not something that was originally described for systemic GIA, but has certainly become a problem, certainly too familiar for some of the people on this call. So this is George Still. He was around, a long, long time ago. And he actually did not name the disease Still's disease. He just described this syndrome of childhood arthritis with fever. And it was some of his proteges in the decades later that called it Still's disease. There are a number of other things that are called Still's. There's a Still's murmur, which is a sort of benign heart murmur, totally unrelated. And he also described ADHD, near and dear to my heart. So the history of what was once Still's disease is that in the 60s, it got lumped in with juvenile rheumatoid arthritis. And it had, it was basically fever and chronic arthritis, and it had a bunch of criteria. And over the years, those criteria have sort of evolved from JRA to JCA to now JIA. And these criteria developed in 2001. And we're not going to go through these extensively, except to say, this is what the textbooks are saying we should be calling systemic DIA. It starts with arthritis. You have to have arthritis in a couple joints for at least 2 weeks, and you have to have a fever most days. It usually follows a quotidian pattern, which is that like once a day, usually afternoon. And then you have to have some other stuff. It can be a rash. Which one is the Still's rash? You've already seen some pictures of Still's rashes. Are they all? Are they none? Where will the salmon land? So according to Google image search, this is the Still's rash, not these other ones. These other ones are the rashes of some autoinflammatory syndromes, some infections, Kawasaki disease. And my point here is just to say, the Still's rash can look like lots of different things. And there's not like a classical Still's rash, but often there is a rash more prominent with fever. Adenopathy, this is just big lymph nodes, and anywhere you can have lymph nodes, they can be big, and that kind of counts. Usually we're looking in the neck, but they can be in the axilla or the groin, or they can even be inside the chest or inside the abdomen where we can't find them on exam. You can have a big liver or big spleen, sometimes pretty hard to detect, especially if you're not going to do any kind of specialized imaging, or if you have a kid who is squeamish or ticklish. And then this thing called serositis, which really is just inflammation of the lining of some of the organs inside our chest and abdomen. So you can have pericarditis around the heart, you can have pleuritis around the lungs, you can have peritonitis around the abdomen. But probably the most important criterion is that it's not something else. And this is the sort of long list of, and certainly not exhaustive, of the something else's that have to be considered anytime that you're thinking about making a diagnosis of systemic GIA/Still's disease. And so, obviously I'm bouncing back and forth between the names. And so why should we decide to call it systemic GIA versus Still's disease? Well, it's systemic, it's arthritis. What's the problem? And changing names is hard. We already have all of these papers and infrastructure and amazing foundations that are named systemic GIA. And then if it's called JIA, we can kind of work together with the other JIAs for advocacy and fundraising. And so there's benefits to being in the JIA field. But there's also some costs. Biologically, it seems just completely separate from all the other kinds of JIA. Genetically, the biomarkers are different. The responses to treatment are different. The adults have been getting along just fine calling it Still's disease since originally described in children. They call it adult onset Still's disease when there's no pediatric Still's disease. And thanks to work from people like Bruno Fautrel, who runs a really nice registry in Europe, we can kind of say that whether or not you have arthritis as part of your disease, it doesn't really make any difference. It's all still one thing. And so, Dr. Fautrel is going to talk later, very recently helped lead an effort where he said, why don't we just call it Still's again? And this is a picture of Dr. Fabrizio De Benedetti, who's also a European pediatric rheumatologist. We're stubborn. Okay, fine, we'll call it Still's. And so the Europeans have decided to band together and say, we're going to call this Still's disease as one collective entity. And I agree with that. Hopefully that will stick moving forward. And so what is this thing, macrophage activation syndrome? Is that the same thing or is that totally separate? So this is the syndrome of macrophage activation syndrome. It's fever, it's some low cell counts, abnormal clotting where they have little microclots everywhere, or DIC, liver involvement, these funny activated macrophages that have eaten other cells, especially red blood cells called hemophagocytes. And of course, this really high blood biomarker called ferritin, with the potential that this progresses into something that looks like shock and potentially organ failures. And here's some of the organs that like to be involved: the liver, the spleen, and unfortunately the brain. So what isn't macrophage activation syndrome? It's not really a cause. It's really kind of a description of the kind of inflammation that someone has at a given point in time. And, I don't really think of MAS, especially for a lot of our patients, as kind of this light switch where you have it or you don't, but really more of a spectrum where, you have, especially the more systemic of our Still's patients, have a lot of these symptoms. And when they become more severe, they hit some semi-arbitrary threshold where we start to call it macrophage activation syndrome, especially when there's some of these dropping cell counts or coagulopathy. So I think of these things in the more systemic flavor of systemic JIA as a spectrum. Okay, so my task here is really to tell you what causes systemic JIA. There's a lot of hypotheses floating around. You've heard the term autoinflammation. We've talked about IL-18, abnormal viral responses. Everything's a virus in pediatrics until it isn't. And then maybe you've heard about this thing called HLH or a genetic problem with your killer cells. And the answer is, honestly, we don't know. It remains a big enigma. And in part, it's because we're probably studying more than one way of getting to the same sort of phenotype. And so, I think every kitchen has a bit of a junk drawer. And I think Still's disease, systemic JIA, is a bit of a junk drawer where they're all in the same place and there's a fairly similar syndrome, but how you get there and what it actually is it can be lots of different things. It can be a prolonged viral response, or it can be regular old JIA, but had a febrile presentation. We talked about Kawasaki's or autoinflammation. So when we say Still's, I think we're still kind of not talking about one very specific thing, but more sort of a group or a family of presentations. So we keep coming back to this term autoinflammation, and what do we mean by that? I won't make my joke about cars on fire, but autoinflammation is persistent inflammation that is not explained by infection or cancer or antibodies or antigen-specific T cells. And so I have drawn up sort of this six-part overlapping wheel of immune dysregulation where you have different categories. And you might be familiar with things like autoimmunity, where your immune system is too much, is behaving badly, and it's responding to a self-antigen, something that's part of you, as opposed to like allergy or atopy, where it's a harmless antigen that you're responding to. Autoinflammation is there's just too much inflammation, but there's not one specific thing, whether it's a virus or a pathogen or a self or a pollen molecule. It's just kind of the alarm for our innate immune system kind of going off inappropriately. And that's kind of what we mean by autoinflammation. So I thought we would talk about the pathology of stills using the characters created by Rashmi in 3 acts. And so we have to introduce the cast first. This is Poly, which is short for polymorphonuclear cell because they have funny nuclei, or we usually call them just neutrophils. And they react really quickly, and they're pretty destructive and not very precise. And then there's Gronk, the natural killer. He's also very fast, responds very quickly to things, a little bit more tactical. He's a bit more of a killer than just sort of spraying destruction everywhere. Then there's Terry, the T cell. Terry is a little slow to respond, likes to see what's going on first, very strategic. And when Terry gets going, very potent and very bossy, likes to tell other characters what to do. And then finally, of course, there's Mac. He's a macrophage. Macrophage, he's always around, and he's very suggestible. Whatever someone sort of tells the Mac to do, it's going to do, and it's going to do it with gusto. And then we'll talk more about these little wee beasties later. So first we have to set the stage. Our cast of characters is home at homeostasis, and they're just living equitably and not causing any problems. And then there's some sort of trigger, and this is where I can't tell you what the trigger is. It certainly could be a viral infection, but it's not always, or not clearly. And so that's our little lightning bolt. And then, our neutrophil, Poly, he's the fast one. He responds really quickly. Hey, I'm going to go check that out. I'm going to go see what's going on. And Poly likes to make these cytokines, IL-1 and a little less IL-6, but makes these sort of cytokines that you might be used to if you're dealing with systemic Still's disease. Gronk, our NK cell, really hasn't helped anything. Our T cell is really not very interested. And because Mac is so suggestible, he's going to go help. And their response might just be this sort of typical initial presentation: fever, swollen lymph nodes, maybe some rash. And then, in the typical course of Still's disease, about a third to a half at least of patients who have a diagnosis of Still's disease have what we call a monophasic course, which means things can be pretty inflammatory, but often we just have to sort of give some steroids or block some of these things, and the patients have a kind of monophasic course. And then, Poly and Mac leave, and the T cell and the NK cell never really got that excited. And so that's the sort of hopeful outcome, but it isn't always what happens. Sometimes there's over triggering. And so it starts in roughly the same way, where you have, your neutrophils and your macrophages responding quickly, and they're causing fever, adenopathy, and rash, maybe a little arthritis in this scenario. But our T cell is kind of paying attention and wants to know, when they're going to be back. And so, if they stick around for a while, especially if they've sort of set up shop inside an arthritic joint, they're going to keep sort of pumping out these cytokines, IL-1, IL-6, and lots of other stuff, and causing some damage. And the T cells decide they better check in on that. And so the T cell says, yeah, there's all this IL-1 and IL-6. They must be detecting something horrible going on. The neutrophils and the macrophages are, I don't know, maybe listening to themselves. They make these cytokines and they can respond to them. And it just kind of persists. And we postulate that this other cytokine, IL-17, that can come from T cells helps perpetuate this process. And that maybe becomes this scenario of the patient who the fever becomes less of a problem and the disease really becomes socked into their joints and really, really hard to take care of. And that's where the T cells become kind of naughty, as they help lock these things in and make them very hard to treat. On the other hand, you can have a massively triggered response. And again, I can't tell you what the trigger is, but in this case, it really seems to drive Mac, who was sitting there unassuming, to just pump out all of this IL-18. And IL-18 can be, really sort of a misbehaving, like an IL-8 teenager. The neutrophils do what they normally do, go and sort of check things out. But Mac has really just been possessed, is pumping out all this IL-18. And, T cells really notice IL-18, respond to it in a very inflammatory way. And so you start with this fever, adenopathy, and rash. But things can escalate quickly with all this IL-18 around. The T cells have really gone nuts. So much IL-18, something must be very wrong. They have to fix it. And the way that this T cell is going to respond to IL-18 is by making tons and tons of this caustic cytokine called interferon gamma. MAC is still just pumping out IL-18 at levels that we see in really no other disease. The neutrophils and the NK cells have kind of left the party. They somewhat respond to the interferon gamma. They might try and turn off this whole process by making something called IL-18 binding protein. So they're trying to bind up some of this IL-18, but it's just not enough. There's too much of it around. And the product of this interferon gamma is that it jazzes up all the other macrophages and other immune cells. It really amplifies and potentiates the effects of the other things that were already around, like IL-1 and IL-6. It makes other macrophages hungry for blood. And here's the little red blood cells that get gobbled up to form hemophagocytes. And that's sort of this trajectory into macrophage activation syndrome, which seems really closely tied to all of this IL-18. And so some of the sort of practical application of that is we can use IL-18 as a pretty good diagnostic biomarker. So this is just a bunch of different things we can measure in the blood, comparing different inflammatory diseases like systemic JIA, other JIAs, Kawasaki disease, systemic infections, and leukemia. And you can add lots of other things to this, but it really is sort of a binary difference where the IL-18 levels in many Still's patients are pretty diagnostic, and increasingly that's becoming part of the way that we make this diagnosis. So do we have two different subtypes? Yeah, it seems like IL-18 defines the more MAS-like and IL-6 the more arthritic-like. And that maybe, IL-18 bridges autoinflammation with this HLH MAS-like hyperinflammation, whereas the arthritis kind is really more between autoinflammation and autoimmunity. So to wrap things up, Still's still widely variable, certainly potentially deadly systemic inflammatory disorder. We still don't really understand the origins of this disease. It has some of this autoinflammatory flavor, but in many patients, it can have an autoimmune flavor. And we're really centered on these cytokines that we've discussed, like IL-1 and IL-6, and this, especially in the MAS-prone patients, this IL-18, which seems to be pretty good at driving interferon gamma. So I'll thank in advance Dr. Fautrel, who's going to do a much more adept clinical summary. I'll end with saying the future looks actually pretty bright for Still's and systemic J. We have a lot of new treatments. We have a lot of good research ideas. We need to figure out some new things, like how do we predict what trajectory somebody's going to take, what's going on with all this IL-18, what's the nature of the triggers that sort of flare our diseases, which treatments and when to stop them, and then really importantly, how do we prevent some of these chronic complications, definitely including lung disease? So the future looks bright, but there's certainly a lot of work to do. I'm really grateful to work in a really great community, a multidisciplinary group at Children's Hospital in Philadelphia that we call our Dysregulated Immunity Response Team, or more legitimately, our Immune Dysregulation Program. And moreover, really happy to be part of this amazing community. Thanks.
Oh, you're on mute, Rashmi.
I'm on mute. Sorry. I
Stunned
was
silence.
framing the first question that is that how can you lower the CRP level for a 18-month-old baby? Can any food or diet help? And this is a question that we often hear.
Yeah, we often get it as well. I think that everybody is on this quest for the anti-inflammatory diet, and certainly a lot of work has been done looking for it, and really there's not much to be found. Now, certainly if there are children that have, bad food allergies, that can be a contributor to inflammation in any context. I can say that every time we look for those, it never seems to be something that makes a big difference. In general, the anti-inflammatory diet is a healthy diet, which is like lower in processed foods and salts and that kind of stuff. So, and simple sugars. So, if you're eating what is considered to be a healthy diet, that is sort of anti-inflammatory, but specific foods, whether it's turmeric or sour cherry or who knows what, really, we don't have a great sense for those making much of a contribution.
Got it. So another question which will about IL-18. Any explanation for the high IL-18 without symptoms, not technically diagnosed with SJIA stills?
Yes, from a audience member with a lot of experience with this exact question. So I think that IL-18 doesn't do a whole lot by itself. It really is there to kind of amplify other things that are going on. So it is certainly possible for people to walk around with really high levels of IL-18, often for decades or years. And we think that those folks can have normal, healthy lives, have kids, have jobs. They're probably at risk for, in certain triggering situations, having a much bigger response. But it may also be that certain people are better able to sort of compensate and regulate that than others. Um, we're still trying to understand exactly how that goes. And there's some genetic diseases where the 18 is never going to come down. In most stills patients, if and when they can kind of get things under control, it can be normal. So we do use it as a sort of minimal residual disease activity marker outside of those rare genetic diseases.
We'll do one more question. Have any answers? How often do patients present with peritonitis instead of heart or lung lining inflammation?
That's a great question, Kristen. I don't have hard numbers for you. Not super often. I'll say I can't say that there's not a little sort of subclinical. When we do see the serositis, we usually see pericarditis. We can see peritonitis in other autoinflammatory diseases, especially like FMF, but it's not a super common part of the presentation.
Okay, let me see the time. Actually, we can do one more question. What was the next one? Are there genetic tests you would recommend? I know Scott will like this question.
You know, it is an open question. I would love to be in a place where we were all kind of just getting genetically tested and comfortable with not having a result that is clinically useful. So, I'm always in favor of early genetic testing, but I think I have to be honest and say that in most stills patients, genetic testing hasn't really changed their clinical, picture outcome. Certainly, if things present really young, we usually pursue genetic testing pretty early. If things have been sort of really troublesome or refractory, we'll pursue it. And that's not to say that we have not found genetic diseases that probably were called stills in the past, and that includes XIEP deficiency, NLRC4 gain of function, and there's a host of others increasingly. So I think that it's a moving target. We're always learning more, but I think in terms of like the day-to-day management of any particular patient, it's not super common that it moves the needle. We still pursue it reasonably frequently. I just, I don't want to build up false hope that like there's a genetic cause and that's going to really alter the trajectory. That hasn't been the case, even in a lot of the refractory patients.
So thank you so much, Dr. Canna. With that,
Thank you.
We will move on to, and he will be back for the panel. We will move on to Dr. Bruno Fautrel, and let me just look up introduce him. He is professor of rheumatology at Sorbonne University and the head of the rheumatology department at, I am going to massacre this word, at the Petit
Salpêtrière Hospital.
Thank you so much. And his research focuses adult onset Still's disease and immune-mediated inflammatory diseases. And he'll be able to focus a little bit more about the adult version of the disease and about medication. So thank you. We are so excited to have you. You can share your screen now.
So thank you, Rashmi. Thank you for all the energy you develop to improve the research and the management of the disease in many patients. Normally, you should see my screen. Is that okay?
Yeah, we see your screen.
Perfect. Actually, I'm an adult physician, But I won't speak only about adults, because now we are all convinced that SJIA and AOSD are the same disease. So really, we move to the direction to say we speak about still disease. And what we will discuss now is the main guidelines for all patients, children or adults. So this is something very important. And thank you for Dr. Canna to have presented all this basic information in order for me just to focus on the management of the disease, on the clinical aspects and the treatment. So either in children or in adults, we have these 4 pillars with the fever. So recurrent fever, very high fever, frequently every evening for more than 1 week, 2 weeks. So very difficult situation for the patient and for the parents when it's children. The rashes are very important. The first description was a salmon pink rash, so something very subtle. Now all lesions corresponding to urticaria are also included. Normally, it's only focused on trunk and limbs, not on the face, for example. So, but the rash is a very important symptom to make the diagnosis. The joint symptoms are also very important. So, sorry. Scott, can I explain to you that arthritis is not mandatory? And we really want to emphasize that just arthralgia is enough to speak about joint involvement. And if you have to wait for arthritis, you will lose time and you will reduce the efficacy, the chance for the treatment to be fully efficacious. In some cases, the joint involvement may lead to erosion, so joint dislocation, let's say, or and this we were used to say that it's approximately 1/3 of the patient who will develop this erosive disease, joint disease. But actually, we have the feeling that nowadays, since we treat the patient more rapidly, the percentage of patients with erosive disease is probably not so high, which is the good news. And finally, the fourth pillar is the increased CRP and the increased neutrophil count. So it means that you have a lot of inflammation in this patient. Besides that, you have many other manifestations that have been described. Scott Canna discussed about the cardiac involvement, pericarditis, myocarditis, pleuritis, liver, so liver function test increase. You have also life-threatening complication, fulminant hepatitis, macrophage activation syndrome. So the situation may be very um, um, reassuring at the very beginning, but it may evolve in the wrong direction. So for any physician, when you make this diagnosis, you have to be very careful about the possibility of some very complex complication. There is also an heterogeneity in terms of evolution. So there was this discrepancy, or this separation between the children form, so SJIA, and adult form, but it's completely arbitrary related to the organization of the care. Systemic features are really very important to speak about cell disease, but some patients will have specific organ involvement or macrophage activation syndrome. And for some patients, there may be a chronic articular evolution. However, in adults, we have the same, as I told you before, the feeling that when you treat the patient very rapidly, you will avoid this chronic joint involvement. So it's something very important. And there is also an evolution heterogeneity. Some patients will have just one flare of the disease. We can't say the patient are cured because a relapse is always possible, but some patients will have only one flare during their life. We don't know why, but it may happen. The majority of the patients will have recurrent flares after a few months, after a few years, and we have no clue, no marker to identify which patient will do a relapse, which patient will remain in remission. And for some patients, we have a progressive disease with a very limited control of the disease, so something which is more chronic. Once again, we don't have very strong data, but the idea behind our recommendation, especially, I will explain that to you in a few minutes, is that the earlier the treatment and probably the lower the risk of chronic evolution. And just to I don't want to go into much detail in terms of pathogenesis of the disease, but we have the feeling that there is two steps in the disease. For some patients, you just have the four pillars, the still disease manifestation. And for these people, for this patient, we will say it's an autoinflammatory disease, meaning that it's a disbalance or a dysregulation of the innate immunity, this part of the immune system which is in charge of the first defense against infection of this kind of thing. And here there is a very important role for IL-1 and IL-18. In some patients, there is a development of macrophage activation syndrome, perhaps also lung disease, perhaps also other organ involvement. And for this patient, we have this notion of hyperinflammatory disease, which means that you have the involvement of the innate immunity and also of the adaptive immunity. The adaptive immunity is the one which is with lymphocyte, for example, in charge of reacting against a specific aggression or infection, and so you developed a very specific response to this aggression. And here, IL-18 is still important, but interferon gamma is also a key player. So this is important just to recall very simplistic way of explaining the disease, but it's a way to see what are our mode of action in terms of treatment. So as I told you, there were some recommendations. It was in 2023, where adult physician and pediatric rheumatologists worked together to identify a few main messages to help physicians to manage a patient with such a disease. So the first, so in this type of recommendation, we have what we call overarching principles. So really big and strong ideas, very general. And besides that, specific recommendation. So in terms of overarching principle, we have decided to say that SJIA and AOSD is the same disease. So now we would be very happy to use the unique name of still disease for all these patients. So of course, you have some differences between children and adults, and children, very young children, are probably more at risk of developing the disease compared to older children, but it may happen also in adolescents or young adults. And macrophage activation syndrome, for example, is more frequent in very young children. We did two other overarching principles. The second one was the notion of shared decision-making, really to be, to involve the patient and the family of the patient into our decision, our understanding of the disease, and what could be the way of managing the disease. And another very important point is to say that we have to adjust the treatment depending on the disease activity. So it's not just a one standard treatment, and which will fit for every patient. You have a global strategy, but it has to be adapted depending on the evolution of the disease and the different marker of the disease. And the ultimate goal for still disease is to achieve a drug-free remission. So we have in mind that it's feasible to reach a drug-free remission. It's not cure because there is a risk of relapse, but still, it's if we have the optimal management of the disease, probably we will increase the percentage of people for which we will be able to stop the treatment after a few months or a few years. In terms of diagnosis, we recall here the four pillars. And so this is a very practical recommendation, but to say that arthritis is not absolutely needed. So, and it's the idea behind it is not to lose time waiting for arthritis. And here we identified two very important biomarkers, CRP, as you know, and ferritin. And ferritin is not fully specific of still disease, but compared to many other inflammatory diseases, ferritin, still disease is the one where ferritin is the highest. And ferritin is very closely related to IL-18. So it reinforces the link between still disease, IL-18, and ferritin. For when we have a patient in front of us, we have to identify the target we want to reach with the treatment. So here we were not fully we use in daily practice some composite indices where we combine the patient global assessment or the parent global assessment, the number of joints involved, the level of CRP, the level of ferritin, if you have some different symptoms of the disease. So here we don't have a unique tool for children or adults. Probably we'll have one in a few months or years. But what we decided to say is what we want to achieve is a clinical inactive disease. So it's a way for us, all the physicians, to have the same vocabulary to manage the disease. And a clinical inactive disease means that you have no still symptoms and that you have no inflammation, no CRP, no elevated CRP or ESR. And remission is the same, the clinical inactive disease, but for a certain period of time. And remission, you can speak of remission after 6 months. It can be remission on treatment or remission off treatment if you're able to taper the treatment and to stop it at the end. And very importantly, it was not the way we produce a recommendation for every disease, but in still disease, it's a very challenging disease, very active disease at the very beginning. So we identify intermediate targets. Clinically inactive disease may need 6-12 weeks to be achieved. And we need before to be sure that we're going in the right direction. So we identified at day 7 that we want to have no fever and to have a substantial decrease of CRP. At week 4, no fever, reduction in joint symptoms, normal CRP, and the physician and parent patient global assessment need to be low, below 20 on a 0 to 100 VAS. At month 3, we want a clinical inactive disease with a low dose glucocorticoids. And at month 6, the clinical inactive disease, but we don't want glucocorticoid anymore. Because one of the problems, and we'll come back to that in a few minutes, glucocorticoids on a long term have many side effects, and we don't want to expose children or adults to glucocorticoids for a very long period of time. This is very important nowadays. In terms of treatment, so here you see in this recommendation that we started the recommendation by to avoid prolonged systemic glucocorticoid use. If you use glucocorticoid, you will be able to control the disease, but you will have side effects. So this is why we recommend to use IL-1 or IL-6 inhibitors, and they have to be prioritized because we have a very high level of evidence to say they are efficacious in this disease. And we added another recommendation to say that this treatment has to be initiated as early as possible. It means that it's not only for people who are refractory to glucocorticoid. It's as soon as you make the diagnosis, it's really recommended to start this targeted therapy if they are available in your country, because it's a way to reduce the exposure to glucocorticoid, and it's a way to control more depth the disease activity. And here, this is what we have in the literature, in the scientific literature. It's 2 studies. One is with anakinra, an IL-1 blocker. The other one is with tocilizumab, an IL-6 blocker. You see here that in terms of clinical inactive disease, if the treatment by anakinra is started in the first 3 months of the disease, you have 92% of clinical inactive disease. If it's later, it's only or approximately 40%. And here with tocilizumab, 54% if you treat the patient very rapidly, and none in this study of the patient achieve clinical inactive disease when the tocilizumab was used later. So very important message: don't wait for glucocorticoid side effect to start these treatments. And to simplify the thing, we did a decision tree where you have the disease. You look at the level of disease activity. If the disease activity is very high, high dose glucocorticoid will be needed. But as soon as the diagnosis is confirmed, then you can go with IL-1 or IL-6 inhibitors. If the disease activity is milder, there is a possibility to only use IL-1 or IL-6 inhibitors and to use lower dose of glucocorticoid, or for some patients, no glucocorticoid. Then we want to achieve the clinical inactivity, inactive disease with low dose glucocorticoid. If it's okay, it's perfect. You taper the glucocorticoid and you maintain the IL-1 or IL-6 blocker. If it's not achieved, then you have to rotate between IL-1 or IL-6 blocker, and then you control 3 months later to see where you are. Sorry. If the evolution is not in the right direction, you tested an IL-1 blocker, you test an IL-6 blocker, the response is not perfect, then you have to contact. In Europe, we have European Reference Network, and we have Reference Center for Rare Disease. In the US, it's not exactly the same name, it's the same principle. And the important thing is, if you see that the evolution is not as good as expected, you have to contact the very expert of the disease to be sure that you don't miss something, that maybe you have to adjust the treatment to add something to the IL-1 or IL-6 blocker. So very important to go to the very expert of the disease. And if it go on the right direction, you achieve clinical inactive disease and you're able to stop glucocorticoid after 6 months, then you continue IL-1 or IL-6 blockers for 3 to 6 months. Then you try to taper progressively the biologic agent up to the complete discontinuation. Of course, each time, if there is a problem, you have to be reachable for physician. We really explain to the physician, the patient have to know how to contact you, and in order, in case of flare, to reach you and for you to react to their symptoms. So a few words about complication. We spoke about macrophage activation syndrome. There is also this notion of lung disease, and Scott Canna explained to you what was this very new and surprising situation. And actually, we had a lot of information during the last 5 years, and now we have a clearer view of what can be done for this patient, and especially after the first description by our colleague in Philadelphia and Cincinnati, there was a European experience with a pediatrician from Italy, Germany, and the Netherlands. And what you can see here is the description of 50 patients with this lung involvement. What you see here, these patients were not new patients. It was patients with a chronic persisting disease. So something children, in this case, with quite refractory disease. A substantial number of them already had a history of mass, so it means that it was patient with very active and severe disease. Here, some of the patients, the majority, but not all, were exposed to anakinra or canakinumab or tocilizumab, so to targeted therapy. There was a question here to see, is there a role of the treatment in the start of the lung disease? And especially there was a question about hypersensitivity reaction to this treatment. Now we know that it's not the case, and you see that lung disease may happen without exposure to this treatment. And the other important thing, you had question about genetic marker. For these people with lung disease, our colleague identified that there is a specific, actually, allele, the DIA-beta 115. This is our genetic code that differentiates individual. And when you do a transplantation, you have to take into account this allele in order to have a good success of the transplantation. And here you see that people with lung disease have a very high percentage, very high frequency of HLA DIA-beta 115, between 70 and 100%. In the general population, it's only 25%. So at the end, what we say in the recommendation is that for people with lung disease, and it's potentially also the case for other organ involvement, it's not a contraindication to IL-1 or IL-6 blocker, but there is also an indication to start another treatment in addition to the IL-1 or IL-6 blocker to control the disease, and especially to control the role of T cells in the mechanism of this complication. And final recommendation, to insist on the fact that there are all over the world still disease expert centers, and for the physician, they have to be in contact with this center in case of any problem in the management of the patient. And my conclusion will be that, so thanks to the different treatment, IL-1, IL-6 blockers, there are major advances in the management of the disease. We think that thanks to this treatment and their earlier use, we are able to achieve clinical inactive disease in a large majority of the patient. Now we have new agents, especially biologic agent targeting at the same time IL-1 and IL-18. So potentially it can be really more efficacious than only blocking IL-1. There is also a new biologic targeting interferon gamma, which is something probably very important in macrophage activation syndrome. We have also already existing therapies that can be repositioned, such as JAK inhibitor. These treatments are blocking IL-6 and interferon, notably interferon gamma. So there are possibilities to use this treatment in future studies. And actually, there is a joint effort and several protocols, several trials building nowadays. And in each case, we have discussion between adult rheumatologists and pediatricians to find the optimal design in the study and to be as the most efficacious in the development of the trial and the achievement of the trial. So this is what I want to conclude on, and I will just thank you all the people who participated to the recommendation and to share with you what I have in front of me because it's spring in Paris.
That's beautiful. Thank you. Thank you so much. So we can move on to a panel part of the event where we will have both the speakers who can take your questions. And oh, sorry, no, first the questions for Dr. Fautrel. So, like, if we have any questions, let me go through that. Luciana or Hani, feel free to um, read out any questions. Let me just. I think there was a question about tocilizumab, if that is the last option for medication.
No, it's not the last option. As you saw, we put anakinra, so IL-1 blockers, and tocilizumab, IL-6 blocker, at the same level. We have the feeling that maybe IL-1 blocker are more specific of still disease, but tocilizumab also work. If you don't achieve the target you want with tocilizumab, there are potential option, additional option to test. And especially this is where, but it's not labeled treatment for which there is an approval, but there is some possibility even for patients who have an inadequate response to tocilizumab. So in our mind, it's not the last option, but if tocilizumab is not efficient enough, then you have to contact the expert center to discuss and to find the optimal option for the optimal solution for a patient.
Got it. I saw this question earlier, which was about it was about, I think, somebody's kid who got diagnosed. How long does the treatment last? Does it come under control? And I think this is question about controlled remission is interesting to address.
So as you saw in the decision tree that I presented, what we want, you want to achieve the clinical inactive disease. If then you want to taper and stop the glucocorticoids, then you maintain the IL-1 or IL-6 blocker, and you will try to taper and to stop. So we don't have for some patients, there is a flare. We don't know why some patients have a flare. Maybe it's the nature of the disease. Maybe it's because they have an infection, for example, or a new trigger that will provoke the relapse. So it's always very difficult. But what we don't have in mind that if you treat the patient for years, at some point, there will be a loss of efficacy of the treatment.
Got it.
Okay.
Actually, on a related note, somebody has a question that I've been using anakinra since late 2002. Are there any other patients who've been treated long-term with this medication?
We have patients who have been treated for years by anakinra or by tocilizumab. You have to know that these treatments have been developed for rheumatoid arthritis, and rheumatoid arthritis is the disease where the treatment are really on a long-standing perspective. It's 4 years. And we know that the side effects of this treatment are not related to the duration of the treatment. And very frequently, the side effects are more at the beginning of the treatment than after several years. So it means that we try to taper the treatment, and if possible, we will stop them. If it's not possible, we are not anxious about some side effects that may appear after 5 or 10 years. This is not what we have observed in rheumatoid arthritis patients. So this is why of course, we are very careful and concerned. We take care of we are very vigilant on that, but we don't have this signal from other diseases where the treatment are really chronic.
Okay, thank you so much. So we'll move on to the panel portion, which really does mean that you can address questions to Dr. Canna as well, or we'll just raise it and whoever wants to answer can. We are also very excited to have Dr. Michael Jordan here, who has joined us, and he's here. So if there are any questions about bone marrow transplantation and in SJIA stills, you can ask those as well, and he is an expert in that area. So with that, let me just.
Hey, Rashmi, can I ask you a quick question? Do we have just a couple of moments for me to talk about the registry?
Yeah, let's do that at the end of the panel.
Oh, gotcha.
Yeah,
I understand.
let's do the panel questions first, and then we'll do that at the end of the panel. One question I'm seeing, is there any connection found between Stills and Cushing's? Don't know if anyone wants to take that on.
Sure, I can jump in. Not in terms of the causes, but I think we frequently refer to someone who has a lot of long-term steroid side effects as having a Cushingoid syndrome or a Cushingoid appearance. And Cushing syndrome really has a lot to do with a overabundance of glucocorticoids in particular, and so we tend to induce Cushing syndrome with long-term use of steroids in patients who unfortunately really seem to need them. But I'm not aware of anything on the front end.
The same for adults. It's really something which is related to glucocorticoid exposure, and this is why we are fighting with our colleague to say there are other options like glucocorticoid for this patient. So you have to use glucocorticoid for a while, but don't stay on high dose glucocorticoids. And there is in the chat a question about BMTs in adults. Actually, it's absolutely exceptional in adults. And probably because the disease is, we have a lot of treatment. And I don't know. Besides that, I don't know. Maybe some of the children have some genetic predispositions that make the disease more intense, but it's very exceptional in adults.
I will just, if I could add a comment to that, it was pretty exceptional in pediatric patients too, till about, I think, 4 or 5 years ago. And then we saw like kind of the patients, 1 or 2 patients go in and then more. So I don't know if Dr. Jordan wants to comment on that.
Yeah, so as a pediatrician, I don't have any direct experience with adult bone marrow transplant. I mean, I agree that it's extremely rare thing in adults, but I agree with Rashmi's point that we will see, right? So, but I think that in children certainly it's becoming increasing much more common.
There's a question for I think this is for Dr. Fautrel. It's an adult patient on Actimera for SJIA. Right now, the fevers and lungs controlled, but my joints have been really bad, and in a wheelchair due to contractures. Other biologics controlled my joints better, but did nothing for my systemic symptoms, which is why we changed. Are there better ones for joints and systemic, or do people go on multiple?
There are people, some of my colleagues, especially in France, are likely to say that for joint symptoms, IL-6 blockers, so tocilizumab, there is another one, which name is saridumab, may be more efficacious. It's not really my feeling. And actually, for whatever the expression of the disease, systemic or joint centered, let's say, I have the feeling that IL-1 or IL-6 blocker works approximately the same. In some patients with really chronic arthritis, we tested TNF blockers, but it's really a few patients, and I don't think it's something which is really relevant. So I can't, of course, answer directly to your situation, but I don't have the feeling that there is a more specificity of one treatment for joint symptoms compared to other one.
Someone is asking that their son's labs, in terms of the IL-18s, IL-2, CXCL9 is all normal. Everything else except for the platelets are still very high in the 500, 600. Doesn't mean that there's still inflammation somewhere in his body. He's been on steroids for 3 years straight now, on Jakafi, steroids, and tacrolimus.
I can handle that one. I mean, I think, if all that other stuff, the CXL9s and IL-18s and CRPs and ferritins are all normal, it might just be that this is someone whose platelet count runs a little bit high. And we've certainly seen patients who have been on mostly JAK inhibitors who, kind of as a benign side effect, their platelets have been running a little higher. So I don't know that in isolation I would be so worried about that platelet count being a little bit on the high side. It can be what we call an acute phase reactant, but almost always in the context of some of those other maybe more sensitive things being up.
Another question I see is about eosinophilia and stills, which is something that we see come up. Is the rash an itchy rash or a non-itchy rash? What to make of the kind of the high eosinophilia, the itchy rash, versus stills, which can often be the non-itchy rash? Or
it can be really tough, and I think that we've talked about the sort of classic stills rash as sort of this red or salmon pink thing that comes with fevers. But you're absolutely right that in some children, especially those who seem to have a more challenging or refractory systemic course, they can have like this sort of chronic, very itchy rash that is associated with eosinophils in the blood, and seems to, at least from my vantage, be part of their primary disease. I don't want to speculate too much about why that might be happening or what it's going along with, but it seems in my experience to be a correlate of someone with, kind of smoldering systemic disease, and the rash itself can be really itchy and disruptive, and also as a sort of marker of the overall stills not being under great control, it can be a little concerning. Steroids work great for that, but obviously we've talked about how steroids are not a great long-term solution. And different places have dabbled with different sort of itchy rash directed therapies, whether it's topical things or even systemic medicines that might be used for people with bad eczema. We have a little bit of experience with that, but it's certainly not a well-worn sort of path for what we do in those situations.
If I may add something on that, I'm not clear about eosinophilia in still disease, and since the description of lung disease, we have the feeling that it may correspond to something specific. So nowadays, when we have an increase in eosinophils, we are looking for the HLA-D habitat 115, and we are concerned about the possibility of an organ involvement, a lung disease, a liver disease, which can correspond to a subset or more active or more refractory disease. So I don't have the conclusion, but for me, it's just a warning that I have to go a little bit beyond and to check some other markers that could indicate that the treatment by L1 or IL-6 blocker couldn't be enough, and then that additional, for example, immunosuppressant agents are needed.
Another question is, are there any upcoming clinical trials for new promising therapies?
Yes, there are with monoclonal antibody targeting interferon gamma, so it's more for macrophage activation syndrome. And in a few months, probably, there will be one trial with a bispecific monoclonal antibody targeting at the same time IL-1 and IL-18. And this trial, it will be completely new, will be accessible for children and adult patients. So it's a really, and it will be a way to achieve more rapidly the number of patients to be recruited to reach a conclusion. So these are the two main trials that are in the process to be developed.
Got it. There is an interesting question about a BMT patient. Maybe Dr. Jordan can take a look at that. They did BMT 2 years ago, and she lost all the donor cells 3 months later, but she's been doing great. And her monocytes and neutrophils are around 5%. Her T cells around coming down. And if you have any thoughts about that.
Yeah. And actually, there was another question a bit earlier in the chat asking about autologous versus allogeneic transplant, I think. But in fact, those two questions, the reason I say that is because there's something kind of similar here. So if somebody has a transplant and they lose the donor cells, let's say completely, in this case, it's not really complete, it's a bit of a mix, then that's kind of the same thing as having an autologous transplant. In other words, you get the really high dose sort of treatment that's the chemotherapy and so forth that suppresses the immune system, and then you get your own cells back, right? And your own cells grow back, but you sort of have done a total reset on the immune system. So, an auto transplant auto transplants have been reported for severe SJIA in the past. There are not a lot that have been done, and there's not, I would say, a lot of excitement about doing them so much. Because the concern is that if you're transplanting children, especially young children, that there may be still some genetic component that we don't understand, and the disease may come back because of that. But having said that, what's been reported previously is that there are patients that will have sustained sort of remissions. And so the question specifically is that the questioner's daughter is apparently doing well despite having lost most of the graft. I would say that we don't know whether the residual bits of donor cells, in this case donor T cells, are basically to be credited, right, with making things better, or it was actually the act of sort of turning off the immune system and sort of starting over with transplant, which is what you also get when you get your own cells back. So it's hard to say exactly, what that means in terms of disease development, but also, which of these two possibilities actually are the reason for why her daughter is doing better.
Okay. Thank you. Scott, do you have any thought? Do either of you have any thoughts about that? About what it says about the nature of SJIA stills?
Nope. I agree with Dr. Jordan entirely, who is a lot more adept at a transplanter than I.
There is one more question about the correlation between successful therapies and patients that are positive for the HLA allele. Do some therapies work better than the others?
No, I think that when you have this allele, you respond correctly to the treatment, but you are at risk of some complication of the disease. So it's not a question of wrong or adequate or inadequate response. It's more about warning for us, physician, to be more careful on the follow-up of the patient. So it's more in that term that I would, we have some patients with this specific allele who are doing perfectly well. They respond only to IL-1 blocker, and that's it. But we consider it's a warning for us, and we have to stay careful on during the whole follow-up.
Got it.
I think it's a really tough question. I think our experience mirrors that of Dr. Fautrel's, where the patients who have this marker seem to have maybe a bit of more refractory course, but you know, the person who's looked at this most closely, again, is Bas Vostert in Utrecht in the Netherlands, and their data suggests that the presence of that sort of genetic risk marker was not actually a risk marker, and the patients who had it seemed to do just as well as those who didn't. So I think that, you know, it may differ based on your geography or your other ethnic background, but it's still something that we're kind of wrapping our heads around.
You have to be aware. Sorry, you have to be aware. Just for everybody to realize that it's we just identified that 5 years ago, and so we are still learning on the exact meaning of this marker. So it's really we at this stage, for me, it's more a warning to be very careful on the management of these patients, but maybe in 5 years we'll have more information to be more precise in how to use this biomarker.
I have a follow-up question for that, for actually Dr. Jordan. I've always meant to ask, given this HLA allele, does it make sense when you're choosing a bone marrow transplantation donor to make sure they don't have the HLA-DRB, that allele?
Well, it's actually it's a really different consideration. So in the context of transplantation, you actually want to match the HLA alleles, because when you have mismatches, that increases the risk of, say, rejecting the bone marrow or the bone marrow trying to reject the patient. So there aren't any honestly any examples of where, let's say you have a risk an HLA risk allele for a disease. It doesn't matter, you know, whatever the disease may be, that we would actually want to mismatch the HLA of the donor and the patient if we had a choice. Now, oftentimes we have to do a mismatch because you don't really have an option. But if you have the option, you actually always want to match the HLA for reasons that have to do with sort of the complications of the transplant itself. You know, the one thing I would say in terms of genetics is that if you have a disease disorder that's driven by a single gene, and you're looking at family members as donors, and you have you would want to obviously not choose somebody that has the same genetic risk that the patient, him or herself, had. That would be the only sort of thing. But that's when you have a disease that's driven by a single gene and not something like a HLA allele, right? We all have human leukocyte antigens. Just the question that some of this put us at more risk for one disorder or another. Right, so you'll have it. It's a question of whether or not it's a match between the donor and the recipient.
Okay, thank you.
And don't forget that 25 to 30% of the general population has this allele. And still disease is a very rare disease, maybe between one case for 100,000 people or 1 million adults. So it's really a frequent allele. And in a very specific context of cell disease, maybe it can be associated with some manifestation. But you have a majority of people with this allele that have absolutely no immunological problems.
Well, thank you so much. Sorry, go ahead.
I was just going to say that just demonstrates. So this is not my area, so I wasn't going to speak to it, but that point actually demonstrates that it's a relatively weak risk allele. Right, and that sort of risk associated with that HLA is just completely dwarfed by the risks of having a mismatch in the context of transplantation.
Got it. Well, thank you so much. I think we've addressed a bunch of the questions that have been posted here. And with that, we will move on to Dr. Jordan, who wanted to tell us a little bit about this MAS registry. Feel free to share your screen and.
Yes. All right. Yeah. Thank you. Let's see. Thank you, Rashmi and Juliana, for letting me tell you guys about this opportunity to participate, and for the for the opportunity for me to do some some advertising here. I just have just a brief announcement I wanted to make about the Into HLH registry that I wanted to make you guys aware of, the opportunity to participate. So we've started this registry a couple of years ago to try to look in greater detail at what we call the natural history of all forms of HLH. And I trained in HEMONC, and I've been studying quote unquote HLH for more than 20 years, and so I use the term very broadly. So it includes the sorts of things that we see in families where we have a genetic form of HLH, but also MAS. I view it as rheumatologic HLH. The rheumatologist might think what we call HLH is more like hematologic MAS, but it's really it's tomato. So when we think broadly, these are all very, very related disorders. It's really true. I think that there are many, many details about HLH or MAS, depending on which term you prefer to use, that we really don't understand well. Things like in the real world, right? How do patients progress to getting diagnosed? What sorts of how do we measure response to therapy? This is actually more complicated than it may seem. How do we choose amongst all the different therapies we have? We have increasing options. And how does the disease and the therapies impact the patients? And in particular, I'd just point out that because HLH, it does have a lot of variations. We see it in patients, obviously with systemic JIA, and we call it MAS in that context. We see it in patients sometimes with cancers. We see it in these sort of genetic familial situations. But we don't understand a lot of these sort of classic familial HLH as well as we do the sort of the namesake. And really there hasn't been an effort to try to compare the different groups to really deepen our understanding of each of them. And so for these reasons, we started this registry. And this is largely sort of a patient-powered registry. So all kinds of patients with any of these sort of diagnoses can sign up via our website or by contacting us to join the registry. When you join the registry, with your permission, the Into HLH team will obtain you or your child's medical records for analysis and enter the sort of abstracted data into our secure and de-identified database. So far, we've enrolled greater than 120 patients into the registry, but only a relatively small fraction of them are patients with MAS. Some are children, some are adults, but it's still a relatively modest number. And really, we think it's important to get significant numbers of all kinds of HLH or MAS type patients to really achieve these goals and understand things better. This registry is run by me and our team at CCHMC. We have support of the pharmaceutical company Sobi, which makes emapalumab and anakinra, drugs that I think this community are quite familiar with. There are some limitations, unfortunately, to this registry, and is that because we do the hard work of actually trying to understand the patient's course directly from their medical record, these records have to be in English. And so we're really only set up to obtain the records from the USA and Canada. So if patients are treated outside, unfortunately, these two countries, we can't really enroll them in the registry. And of course, this is a laborious process, so it takes time. So we've been open a couple of years, and we're hoping to publish our first report later this year. So I'll keep you posted. But just practically, if you're interested, and like I said, anybody with the diagnosis of HLH or MAS, or even the suspicion of that, frankly, is technically eligible to enroll in the registry. And so we can, everybody can contribute to improving sort of understandings and outcomes, hopefully in the future. So you just go to the registry. Their website is right there. That you'll, if you actually, click join the fight, you'll get a secure link to allow you to electronically join the registry. Alternatively, if that's a bother, then we're happy to help you via email and by phone to simply sign up in a more conventional kind of way. away with sharing like a PDF of the consent. But it does take a few minutes because we need a little bit of information in order to get records from the hospitals. We need a little bit of personal information. Again, we keep this all secure, but this is just sort of essential to actually get all of the records from all of the institutions where somebody's been treated. We are at great pains to make sure that all of this is securely maintained and the privacy is absolutely respected. And as I mentioned, the database itself is de-identified, and so we're not. When we publish things, we're publishing things about the groups of patients. So there's nothing in anything that's going to ever be shared that is sort of personally identifiable to the individual or to your child. So like I said, we also have an email address if you just want to email us directly. You can hit contact on the website, and that'll also connect you with the team. But that's the website address there. So if you want to check it out, I would say feel free to look around. If you just want to be informed, you can actually just stay on our email, sort of on our contact list. We have a newsletter we're trying to send out a couple times a year. But we would really appreciate it if you would consider joining for yourself or your child, or spread the word to your friends and contacts that may also be potentially eligible to enroll. Because really, the way this project is going to work is if we can get a large number across a wide array of patient sort of situations to really compare and understand deeply what happens to patients once they're diagnosed. So thank you very much for your attention.
Thank you. And I have joined for my son, and it's pretty easy to join. Really, the hard work is for the researchers. For the patient perspective, it's pretty easy. With that, I was just saying, well, thanks everyone for sticking around, for joining this event. I hope like the breakout group was a good, interesting learning experience. And thank you especially to the experts. Dr. Fautrel had to leave, but thank you so much to Dr. Canna and Dr. Jordan for joining us and for helping answer so many questions. We are really grateful. And we will send out a follow-up email once we have the recording and with a bunch of the links that we mentioned. And we do hope you join Dr. Jordan's registry and our patient membership form as well that I mentioned earlier. It's all very quick. Thanks so much. So on that note, we will end this meeting. Thank you for joining.
Thanks, Rashmi. Bye-bye.
Thank you. Thank you. Bye.
Thank you.
Bye.